Hello, everyone. Welcome to okay, what's the edition of this? I was meant to look and see. I think it's our ninth or 10th podcast. Um, it's,
It's your 11th, actually,
oh my goodness.
because I just listened to your 10th.
Well, it is great to have Steph Connor on here to correct me when I'm wrong and also share a really exciting piece of scholarship from our April issue of POCUS Journal. I'm Dr. Benjamin Galen. My friends call me Jamie. I have several friends on this call, so it's really exciting to record this episode. The article that we're talking about starts on page 45 of the April issue of POCUS Journal. It's called Demonstrating Feasibility of Point of Care Ultrasound Guided Inpatient Transthoracic Echo Triage Decision Pathway. So I want to have our guests here introduce themselves. We'll start with you, Dr. Connor, since you're here. Tell us about yourself.
Sure, thanks. And thanks for having us on. I'm Stephanie Connor. I am Associate Professor of Medicine at Columbia and also the Medical Director for the section of hospital medicine there.
We always ask our guests about their first kiss with point of care ultrasound. When did you fall in love with POCUS?
Yeah, sure. So I was a third year resident. Actually, I was on an overnight malignant heme rotation, which was my least favorite rotation of all of medicine. But I had been in the ICU the rotation prior and just got lucky that my ICU attending had just been to the chest 2-day course. So he came back super enthused about the things he had learned at chest and then was really teaching us a lot during our ICU block there. And so I'm on this malignant heme rotation like a week later and had this young kid who had AML and he like didn't look right and I couldn't quite put my finger on what was going on, but I just knew like something was wrong. And so I decided to just kind of like wheel the ultrasound in for really like lack of anything else to do and just wanted to kind of take a closer look. And I didn't really know much at the time. I only knew how to do, I think, a subcostal and an IVC. And so I like plopped the probe on. And again, didn't really know a lot about POCUS, but just kind of knew that what I saw was not normal. I saw like a tiny heart beating really quickly in this like big sea of black and was just kind of like, uh-oh. And so I took a video with my phone, sent it to the cardiology fellow overnight and was like, what? This seems bad. And they got him to the CCU and did a pericardiocentesis like that night. And really just kind of left that experience being like, everyone needs to know how to do this. Because you could easily see how that would just be something that would like dwindle into the night and then, and then end up in a code. And then I feel like, since then, one of the things I've really loved about my career through teaching is I feel like I get to see a lot of people's first kiss with POCUS, even when they're just kind of like little things like being able to, detect an abscess under the skin or something like that. And it's just been really rewarding for, to kind of keep having that experience throughout my career.
Awesome. Thank you so much for sharing that. Those cases stay with you forever. Your colleague from WashU in St. Louis, where this study was done, tell us about yourself, Mustafa.
Hey, thanks for having me also. So my name is Mustafa Husaini. I'm an assistant professor, pretty sure it's assistant professor actually. But it's been a while losing track of time. But yeah, so I am one of the medical directors on the cardiology firm service, which is kind of where Stephanie and I kind of work together. She was a medical director for one of the medicine units, and then we're trying to come up with ideas of things, how to improve care, make things better. And I think just some common interest align, both with one, POCUS, two, me being a cardiologist, and three, our wait times for inpatient echoes were exceedingly long. And trying to figure out how do we be creative, do something that's fun, but also kind of move care forward. So it's amazing that we kind of were able to get started and get this kind of project up and running and then get it to a good spot before Stephanie had to leave us and go back to the East Coast.
Wow, that's a great background. And now tell us, do you have a sort of first kiss or a first time you fell in love with point of care ultrasound? I know as a cardiologist, echo is a part of your every day, but the POCUS part of it, not everyone, is as enthusiastic about that as you.
Yeah, I think what I was thinking about this when you asked Stephanie that same question, and also what I'm going back to is my first year as a fellow overnight doing my own ultrasound, which is kind of like is that POCUS? Is that an ultrasound? Yes, I had a theater machine doing it. But when the first time I actually got some images in the surgical IC that I actually could see something, I'm like, this is sweet. I love this. Because you can kind of get information right away as you're integrating all the other clinical information. But I feel like I've done so many ultrasounds, echoes, et cetera, that they're all blend together otherwise. So I don't have a story nearly as cool as Stephanie's story, unfortunately.
That's okay. The all the cardiac cases blend together. Dr. Thamman Ritu needs no introduction. She's been on the editorial board of POCUS Journal for, I want to say, 10 years, or the founding, really. She's a founding member. It's such a privilege to have you here. Tell us about yourself.
Hi, everyone. Thank you for having me. I am an associate professor here at the University of Pittsburgh School of Medicine and multimodality imager, focusing primarily on echo to begin with, but as the career has expanded into other CT, MRI as well. I got into POCUS through Twitter and Amr Jory, who's an incredible person also, wanted to sort of talk about POCUS online. So I created a tutorial on POCUS, and that led to a mission event that the American Society of Echo hosted in West Virginia, where we did POCUS on 500 people off the street. And if you know anything about West Virginia, they have coronary disease 10 years before everyone else does. And so we picked up about 10% of cases. So it was the first time that you could see how access to care would really change clinical outcomes. And so it's been a fascinating journey for me since then, of course, accelerated through all the COVID POCUS need. And a lot of deliberations over, POCUS, not POCUS, how do we code for this? How do we differentiate between a regular echo? So it's an ongoing journey. I'm so happy to be here to discuss this case.
Amazing, amazing. It's, the backgrounds and context that you've all shared really sets the stage for this research study that we're going to talk about. And so I was thinking, as you were, telling about the history here, the devices have gotten smaller. Devices have gotten into the hands of a lot of different users over the last 10 or 15 years. The study we're talking about here is identifying hospitalists as users, which, Steph Connor and I are both in hospital medicine. So for us, this is every day, but this is still new, and we're figuring out how to use POCUS to help patients. We know that it provides better, faster care for our patients, but how do we use it as a system? How do we use it as a resource, and how do we hit other goals like reducing overuse of unnecessary imaging studies, cost consciousness, length of stay consciousness, but also not missing important diagnoses. And so setting the stage for that, the folks from WashU, tell us a little bit of the background, how you found a gap in the literature, whether it was the user. I know you mentioned that the BNP-based echo triage history, and I know, Ritu, you had some other insight you shared earlier about some other studies that had done similar, pathway kind of work. So tell us a little bit about the gap you were addressing here.
Yeah. As Mustafa mentioned, so he and I had connected because we were both had leadership positions in the resident units. Mine was on medicine, his was on the cardiology units. And it was a really interesting leadership role because it was kind of a simultaneous leadership role in the residency itself, but then also with the hospital, and really trying to kind of help link the residency with hospital goals. And, I think like many institutions, especially coming out of COVID, having, a ton of problems with borders and resource scarcity, or like even relative scarcity, and wait times, and really having this big emphasis on things like length of stay and throughput. So that was kind of something that we were tasked with. And I think one of the things that I noticed, in my career, I've been at a few different institutions, just kind of following my wife around the country as she does cardiology training, interestingly. But every institution has the thing that they that is like a gap for them. And the one that was, I think, very visible at WashU was the length of time it took to get TTEs and just the sheer number of them, because WashU and Barnes Jewish is a huge hospital. I think it's 1,200 beds, and the volume, just the sheer volume of, is it more? It's more than 1,200.
I think it's up to like 1,400 now, and then
Yeah.
with the
Well,
new
they
heart
were, yeah.
and vascular tower opens in October, it'll be even more. So
Yeah. And so just the sheer volume of TTEs that were being requested, and the amount of time it was taking to get them done, and the fact, you would order it Thursday afternoon and you'd be like, well, I guess we'll, see them by Tuesday. And, it was through no shortage of hard work from the sonographers or the cardiologists trying to answer this volume, but it was just that it was, an insane volume. And so, we had seen the BNP, I had seen the BNP paper. I had talked to a few cardiologists about so what do we really think about BNP? And then, I think one of the things that was really interesting, and we touched on this a little bit in the paper, is this notion that people just order more echoes now than they used to in the past. And I think even when you have something that's like a biomarker, it doesn't satisfy that question that people always have. And even a BNP, right? You're talking usually about one kind of primarily you're talking about heart failure, and our inclusion criteria were for conditions that were broader than heart failure. And so I think we were really trying to kind of bridge that gap of meeting this, or needing to meet this huge volume, but doing it in a way that that also was satisfying to the clinicians who were trying to order this test for a specific reason, and seeing if POCUS could really be the thing that answered that question for them in a more limited and faster way than ordering a full TTE.
Yeah, excellent. That really sets the stage. I mean, I think people who are concerned about oh, POCUS is going to put the echo lab out of business. We all know that's not the case. But to hear you say about that delay, I mean, in my mind, it makes total sense that so many echoes really don't change management or are unchanged from the one last week, and finding a way to connect clinicians who order echoes to the lab and the cardiologists that are reading the studies as a big picture, strategy to get the ones that are really needed faster, is really so important. So I think there's a lot of need for this kind of work. And as I was saying, I think that the way you did this study and designed it as implementation, as well as many aspects of research, from the survey to the kappa statistic analysis of the cardiologist versus the hospitalist POCUS user, is such a high bar and the right way to do this kind of research. And it really sets that bar high for other work in cardiac POCUS, but all other aspects of POCUS. Tell me, Mustafa, you said you'd had some similar challenges about getting echoes done. As a cardiologist, how did you kind of thread the needle about this study being we're doing a cardiac POCUS study, but we're not coming after your RVUs? How does that fit in?
Yeah, it's a really good question. And I think there's two components, and they parallel a lot what Stephanie said. The first is, we round on inpatient service. And when we order an echo on a patient, I want to see that result so I can kind of figure out what my next step is in management. And as you alluded to, that certain echoes probably a little more higher priority than others, but our categorization system, getting them down there is not always right. Urgent, stat, et cetera, right? Especially when we're on the floor. And so that was the first thing, right? The second thing is that when we're reading echoes in the echo lab, so many times we're inpatient echoes, I'm just this is a normal study. This is we don't need to do this, right? And so seeing both the input side, waiting for my echoes to get done for my inpatients to make a decision, while in the afternoon I go to the echo lab and read all these other echoes where I'm my patient could have had theirs done by now that didn't have this for pedal edema for an inpatient, right? It's one of those things where that dichotomy clearly made sense to me. Okay, here's clearly a way we can reprioritize these, and those inpatients that need it can get it done, and other ones, okay, yes, as Stephanie alluded to, a biomarker or some other test might not be enough to satisfy that clinician's kind of desire to get a good conclusion of what's going on. But that'd be the perfect time to say, hey, can we get this done in the outpatient setting? And going back to the conversation about RVUs, this is a business at the end of the day. We also know, at least when we did the study, when there's site neutrality rules not in effect, outpatient echoes also reimbursed better than inpatient echoes, right? And so it's kind of a win-win-win situation. And so when we kind of designed it and thought through everything, we're really not going to show potential decreases in our inpatient echo revenue generation because that volume is already there, right? It's basically a spigot being lost because people don't want to wait and then they end up going home or going somewhere else. That it wasn't really a big concern once we kind of dove into what the actual mechanics were of where these patients were going and what was going on with everything. So
Really glad you mentioned that. I noticed that as a key part of the design. It wasn't canceling the echo entirely, the option to defer to outpatient. That was a critical part of the algorithm. You can see that on page 46 of the April issue of POCUS Journal for listeners. It's figure 1. We're going to get there and go through it a little further. Before we do, anything else on background on the study? Ritu, you had mentioned, I think, some other work that you were aware of that did similar.
Yeah. So I think this is an excellent study, and there has been actually a randomized controlled trial that was published, actually presented at EuroEcho in Berlin in December. Partho Sengupta did it out of Rutgers, and it's called POCUS Care. And precisely the elements that we're discussing, what they did was randomize patients coming in through the hospital any which way, emergency room or admitted with shortness of breath. And half of them got randomized to getting a POCUS and the others did not. And so the ones that actually got randomized to POCUS were found to have one whole full day less length of stay, especially when the acuity of care was less. And even those patients that had higher acuity, they also had a decreased length of stay, such that they saved about $1.5 million just by implementing the POCUS. And clearly it doesn't reduce the number of echoes like Mustafa and Stephanie were just saying, but in fact, it just makes it more efficient. And that's what we're getting at. And the study will be published soon, full length. And I think that's a really important point to make for both sides. It is a business. We're not losing. We have so much work as cardiologists in imaging between all the cases that are, going for clips and TAVRs, and I never see a normal echo anymore, ever. I can't even remember when that was. So it's just, this is the way it has to go in this direction.
It's so great to hear your perspective. I'm so glad there's some parallel work being done that's going to, support this, the spirit of this study as well around cost saving. And I think as a system, we evaluate our trainees on their cost consciousness, and yet then we turn around and there's a troponin of 0.03 or chest pain we can't fully explain, and we get an echo just on the perception of, I don't know, making us feel better or making, I guess, the perception of medical, legal, liability around, oh, they had an echo, and patients feel better having had, sort of some kind of imaging or some kind of test that shows their heart is okay, even though, it doesn't really establish all aspects of a heart being okay. Let's dive into some of the methods. The choices you made, I think, are outstanding in terms of a design, and also the way you did data collection, the way you went through it. So I'm curious for our listeners to hear a little bit of how you designed this pathway that's on figure 1 on page 46. Any sort of earlier versions you had of it, or if you could do it again, would you do it differently? Like those kinds of things. Walk us through that figure 1 around kind of the big picture method.
Yeah, for sure. So I think this was the algorithm that we developed with I'd say the future state in mind, right? Because the key point about this study is that it was a feasibility study. And so in our current study, no TTs were actually canceled because of the triage pathway, right? The whole idea was that we were going to kind of like develop it, prove that it could work, and then, and then go back to all of the stakeholders and say, like, look, here's what we could do with this. And so I think actually designing that with the end state in mind was really helpful. And that's how we got to this, where essentially what we were doing is saying, okay, let's just assume the TT is going to be ordered, right? Because that is baseline and that is current state. So then we can, assign somebody to look at to have our inclusion and exclusion criteria that hopefully has some clinical background, but we were at the time even working with a research assistant who hadn't yet gotten into med school. And so it was someone who we could kind of like train to our inclusion and exclusion criteria and say, just look at the TTE work list and see what of those you could pull out based on our inclusion and exclusion criteria. And then, you know, if they were not meeting those criteria, then fine, then you just kind of keep going with your TTE and, you know, and get that done. Then we said, okay, so we'll pass along those patients and put that into this queue for somebody who is doing POCUS. And so our group was primarily hospitalists. We did have one senior resident who had also undertaken quite a bit of POCUS training and is now currently a chief and a future cardiologist. So he was in our group as well, and said, okay, let's have them do kind of a basic, like a true POCUS, cardiac POCUS protocol. Clip all those images, interpret them, and then say, okay, based on what you know about the patient now, clinically and with the images that you got, do you think this person still needs an inpatient TT or not? Or would you change it to stat? Would you cancel it? Would you, like cancel it entirely, defer it to outpatient, and then kind of use that as the framework for this? And so I think for the most part, this was pretty much from start to finish how we designed it. It didn't really change all that much. And I think unless Mustafa, you remember differently, I think a big part of that is the fact that, you know, our group was both cardiologists and hospitalists. And so it was really, and a resident. And so it was really people who knew the patient population that we were talking about, and were able to kind of come to this workflow pretty quickly.
Yeah, I just want to add and kind of emphasize what Stephanie said about like, I think the biggest time that we spent thinking about what we're trying to do here is right after those images got done, because that's the main decision point, right? Like, because it's in the real world, right? If someone's doing POCUS, then they're thinking and integrating. This is my patient. These are my images. What's next, right? And that's a question of like, oh, this is something really big. I need to get a formal echo, talk to the cardiologist, or hey, I'm not exactly sure, kind of in the middle, or like, this is completely normal. We can move on to the next thing on the differential. And so we spent a lot of time there, and we figured out the methods for reading and blinding and everything else based on that decision point. So I think for us, that's the biggest point where we can say, hey, yes, there's some value in what we're doing here. And that's what we're trying to focus on.
Got it. I just want to make sure I'm clear. So in the figure it says defer to outpatient or cancel, but that was a determination made. But in actuality, for that patient, it wasn't canceled because this was a sort of simulating what would be an algorithm that could be used. Okay.
Right. Correct.
And speaking of that, just a question. You could layer on an AI algorithm to what you have in your findings as your second paper from this, either using Caption Health or, others, AI platforms that see how much of an agreement you get. I would be really curious to see, because I do think you're moving in that direction where a lot of this triage will be done, with utilizing these AI algorithm tools, or even those that are novices that are not cardiologists or hospitalists or anyone. And, but they can just be guided, turn around here, twist, rotate, and get the image based on guidance.
Absolutely.
It's
really so exciting. No, you're totally right. Steph and I talked about this just the other month. I think at the time the study was done, that technology I think wasn't probably immediately available. But you're totally right that a triage pathway, a lot of other radiology, a lot of other imaging fields, use that, especially for like alarming findings. I think that's definitely something coming. You raised a good point about the user experience, and if we could just touch on briefly, what qualifications did the hospitalists who were involved in the research here, what did they have as far as their own skill level is a good question, because I think there are listeners out there hearing this and reading the study who are thinking to themselves, how good at cardiac POCUS do I have to be confident or capable to say this is enough, for routine syncope, this is fine, I don't need a formal echo. So what kind of bar did you set for those users, Steph?
Yeah, sure. So there were two of us who had finished a certificate of completion pathway. So I had done SHM, and Mohammed Ramadan had done chest. So he and I were both had gone through the full certificate, which is fairly extensive. And then three of the others were in process of their certificate, the SHM certificate. All of them had done the two-day courses and were like working their way through their portfolio. So when we did the math on it, it worked out that they were upwards of 20 hours of formal instruction plus an additional like self-instruction or practicing at the bedside. And then Carl Wallenkampf, who's the resident who is doing this, had basically taken part in everything that the residency had available to him at the time, which was they were piloting an elective. One of the attendings at the VA, Ian Ross, is an incredible sonographer. He's a POCUS guy, and had done like one-on-one instruction with him for hours. And so we kind of got like again, about 20 hours of an estimate from Carl's hands-on skills, and then kind of like the blessing from Ian, who is somebody who I just like really trust in terms of his judgment. So yeah, so I think we were all kind of on a spectrum there, but everyone had, experience enough that they would know what they were looking at. They would know good images from bad images. And certainly I think one of the things I was worried about would know that if they were seeing something alarming, that they would, be able to identify that very readily and say something.
Yeah, excellent. It's really helpful and you can see in the paper there's some details about those, the training and background they had. Before we move on out of the methods, I do want to ask a little bit about some of the inclusion and exclusion criteria. I noticed actually syncope wasn't explicitly listed as one of the. I feel like that's an echo indication that's often overused. But some of the other ones, like around, I don't know, mechanical valves and other things that, just in terms of the generalizability of this kind of protocol, what kind of things did you not want to take a risk with and include?
I mean, I think so. One of my biases is is in valves with cardiac POCUS. So I think that was a major reason we didn't include syncope, was that, it's not just new heart failure generally that you're looking for, right? It's, does somebody have significant valvular disease or other structural heart disease? And so I remember us having a conversation about that, and that was my hesitancy. I know there's been, I think it was a multidisciplinary group that kind of came out with this guidelines for POCUS, and they do include valves in it. I tend to be on the more conservative side personally when it comes to valves and and POCUS in general. So I think that was a big thing for me.
Yeah, and just to add on both valves and for syncope. So I think for valves, I mean, a lot of it, so much of it is color and Doppler integration of everything. And from a POCUS standpoint, like that's, yes, that can be done, but it's so much more variability with it. We just want to get things a lot cleaner, just because that's a little bit more realistic. So I think there's a very smaller percentage of POCUS trained users that actually going to be doing color Doppler and integrating all the other aspects that we use when we're reading a full echo on a patient with a prosthetic valve or whatever that may be. The thing that the syncope was a discussion point. This is, I think, a hard discussion point because it goes back down to like the history and physical, or like, yes, a majority of syncope, right? You can diagnose with the history and physical. If it's vasovagal, you absolutely don't need an echo, right? I think the hard part is that we don't want to miss HCM and other kind of scary things that on POCUS, if someone's not really comfortable looking at the wall thickness, doing the measurement. And again, like, and I think we alluded to this in the manuscript, is that like, it's actually really hard looking at POCUS images, because for us as a cardiologist, I think I was looking at 2 to 10 images versus like 60 on a regular echo, right? And so I can corroborate what I'm thinking in different views, right? If there's foreshortening, if there's shadowing, other things, and be much more confident of my read on a formal echo versus on POCUS. And I think with POCUS and syncope, in a perfect world, yes, none of those patients with vasovagal syncope would have an echo ordered, but we know in reality we just can't. We don't know what the denominator is, and I think because of that, we say, hey, from a safety standpoint, let's not include syncope because we actually had so many other indications already.
Right,
So
there's plenty of indications that are worth going after. Save that one for another study. I
yeah,
totally agree, and I do think for our listeners, it's important to know the limitations of POCUS and image quality and number of views and not having spectral Doppler. I think you used several devices. I don't know if Lumify at the time doesn't have spectral Doppler. So in a case of a mitral prosthetic valve, like the 5 millimeters of gradient change can be hugely clinically significant. So that's not a POCUS determination. So I get that. It's a really good choice to exclude those and then think about the patients that plenty of echoes with other indications to go after.
Yeah, I think we weren't at a loss for for numbers, even with the ones we did include, and I think it again goes back to it being a feasibility study. And one of the things that I think a lot about when it comes to feasibility, and this was something that the senior author on the paper, Jing Li, she's an implementation scientist, and so a lot of actually how we frame this is around thinking about, so how would we actually implement it? And when I think about feasibility and implementation, one of the biggest things is making sure that you have buy-in and like true engagement from your key stakeholders. And that's kind of valves overstepping on Doppler, getting involved in congenital heart disease and devices and VADs. Like that's a surefire way to kind of piss off your cardiology colleagues and your cardiothoracic surgeons. And so if you don't need it, in my opinion, it makes sense to start a little bit smaller than that. Start with things you can deliver on, and then gain that trust and expand from there as you can.
That's a great point and a really nice segue to the next thing I wanted to discuss, which is on the next page with the three aims. I really like how you included, the survey type of data, which on its own, is sometimes limited, but you have so many other outcomes. But having survey data around the provider experience and the patient experience, like that's so great. So how did that? Because sometimes you're doing a study with this kind of like more numerical outcomes. Like how did you decide to prioritize keeping that in? Is that part of an implementation methodology or
Yeah, definitely part of the kind of the implementation methodology, right? Of thinking about who are all the people that are going to need to engage with this, and in making sure that you're including them. And so that was really kind of the main driver behind that. And I think also, again, thinking about it from Mustafa and I coming at this from kind of the leadership position that we had, it's like, okay, what is the information that we're going to need to be able to engage people, convince people, and use this going forward. And so that's where I think making sure that we had a good baseline of understanding, like just how open to this or opposed to this idea are people. And so knowing there when we go and we talk to these groups, where is it that we're going to need to to target and kind of like make sure that we're messaging, versus like where are there places where people are already actually kind of on board with this. And so I think the survey was really helpful from that standpoint. And then from the patient standpoint, I think this is something I saw on like a single center ED paper once, like a decade ago, where they did very similar questions, where it was just basically, I thought of it as really just kind of corroborating what I've experienced at the bedside, which is that patients love this. They love when their doctor can talk to them, when they can like see their heart beating on the screen. And so I just really wanted to be able to actually capture that patient experience as well.
I agree with everything Stephanie just said, but I do want to add that I think one thing that was really helpful for this survey that we sent it to all the cardiologists in addition to like hospitalists, nurses, the hospital administration stuff. And we actually got a lot of really good feedback in the comments as we were kind of refining our inclusion and exclusion criteria. So it's one of those things where like not is it just getting a good baseline of like where are we at? What do people feel about it? How do we kind of once we get this data, what do we think about from next steps? But actually getting people part of the solution and saying, hey, like, what do we collectively think is a reasonable starting point? And I think that actually was a really big kind of a win for us to kind of both get buy-in, but also help improve the the manuscript and the project all at the same time.
Yeah, no, I think, echoes aren't bankrupting our healthcare system alone, but we're all patients, and we all pay for this. So the idea that the community of all the stakeholders is going to be involved in the buy-in, it makes total sense to me. I really like that. The next part I really appreciated was the kappa statistic analysis comparing interpretation. So can you unpack that for our readers a little bit, or our listeners? How did that come about? Was anyone worried about that? Were the hospitalist users like worried that they were going to be inferior in a way that would impact the study? Like how did it go?
Yeah, I mean, maybe I was more worried about it than anyone else, just because I was like, well, this would be, like a terrible outcome for, basically like building my career on this, and then just to do a study that shows that we're terrible at it, like that would have been really, I think, kind of a bummer. But no, I mean, and this is where, again, working with Jing Li, like she was a really, really intelligent, really smart when it came to how you do these kind of study designs. And I think, referencing some of the other papers that we've all seen that are, old at this point, like 10 plus years old, where you look at one of these variables in comparison, to like echo to POCUS, and kind of show this agreement. And so, yeah, so that was really the idea behind it, was just to kind of, again, thinking about this as a feasibility study. One of the questions I think you have to be able to answer, and to Mustafa's point, we saw this in the comments, is, can we do this like with any sort of, like with any reliability? And so it was important, I think, that we show that we can. And and interestingly, we'll, I guess, get to the results, but I also thought that it was to me, it read as very valid and true, right? That the things that we know are like quote unquote easy, like systolic function, LV systolic function and pericardial effusion, had, almost perfect and substantial agreement. And the things we know are harder because they require more views, and because they are more subjective, things like the LV size and stuff had less agreement. And so I think that really kind of rang true to what we know as the limitations of cardiac POCUS versus, full echo, and also aligned really well, again, with what we, the clinical indications that we were really going for, and what TTs we were trying to pull off. Like we weren't trying to pull off the ones that were definitely necessary. We were trying to pull off the ones that were, lower value.
Yeah, I mean, I think actually we can jump right in to follow up and talk about table two. I know we're moving through the other sort of survey results, but it's such an important finding. I mean, what you're saying here is that it's not a given that the hospitalist who does the SHM certificate of completion, is able to make a determination on LV size, or sorry, pericardial effusion and LV systolic function, with acceptable interpretation skills to a cardiologist reading those same images. So I think that alone is a really important finding as a result, not just the way it's implemented, but that's I think really exciting and validating for those users, and for the training that they've undergone, that it's sufficient for those determinations. But you mentioned that a couple were not quite as the kappa was lower, and that was something you also expected. It was the LV size was something that struck me. You mentioned that is not it's not easy to do, but eyeballing compared to, like, is there a pericardial effusion or not? Maybe it's not the most important part of POCUS. You could argue that too, but Mustafa, what do you think?
I was actually going to say that exact same thing, right? Because it's like so many of these findings, or we care about in POCUS, right, is more chronicity too, right? So things acute, obviously we care about that. That's going to change things. So there's more chronic, does it really change our decision at that point in time at the bedside? And I think LV size is a great example of it, right? Unless there's like toroidal aortic regurgitation and the LV is ballooned up within like a couple hours or days, like yes, but like for most clinicians, you'll see that clinically on the history physical, right? And so does POCUS really add a lot from that standpoint? It probably doesn't, right? And going back to what I said earlier, like we get so many measurements, we use contrast, like we get a much better sense of LV size. And in this case, we didn't obviously do numbers. It was much more of a like, is this hyperdynamic? is this, or is this like small and hyperdynamic, right? Is this just big and dilated? Is this somewhere in the middle? And even then, there's a lot of disagreements, and I think it also just shows just how variable this aspect is of it.
And just to piggyback on to what he's saying, there is a lot of variability when assessing LV size, and we know from current studies, LV size is best measured in 3D and with contrast. And so when you're just getting, a view on POCUS, we largely say either it's looks normal or it's, or it's not normal. It's not really that qualitative as one would, expect with a regular echo that's it should be done in 3D. Certainly the RV, you cannot assess size because of the shape and the anatomy of the whole RV. So I think it was interesting and concurs with the other literature that's out there that the largest variability was seen in LV size and RV size, in terms of discrepancies.
It's interesting to think of how to build on this finding because, the question I would ask is, should POCUS users sort of avoid that result altogether, unless it's an extreme finding, like Mustafa said, like where something is really abnormal, or cases of obviously dilated or known dilated cardiomyopathy, kind of reevaluating, appreciating what LV size looks like, sort of subjectively, but it may really maybe not a key component of the cardiac POCUS exam, because cardiac POCUS is an evolving term. I know we had a review article on the topic of, this goes by so many different names, but when does cardiac POCUS touch into the area of limited echo, and when does a limited echo become an echo? Maybe these kinds of results help us to decide as a sort of field collaborating that LV size may just be a variable we don't consider to be part of cardiac POCUS, that it's something too difficult to interpret accurately with our tools at this time.
It's like you say, I mean, it's an evolving field. It's going to get better and better. Right now, with butterflies and the units that are out there, we can't use contrast, but eventually we will be able to, and it'll be a game changer even for POCUS in the fields. And so I always, you just qualify it by, it's an evolving thing, and what it's going to be in a couple of years, I don't know. But obviously we are looking at size. We're measuring EF, so you're checking diastolic and systolic volumes, or size in 2 dimensions. So we are doing it. It's just, that gives you a range, and not necessarily, you're not wedded to that one number only, it's 47.5%, it's not that, it's giving you a range. And I think that's important for our listeners and people who do POCUS to remember that.
Yeah. And I think too, right, it goes along with with your experience, also with your individual skill level, with the patient, the various patient things too, right? Because it's like, we all know, right? Some patients, you can get amazing windows on every view that you try, and others not so much. And, and so I think part of what comes with that experience though is knowing, okay, is this a variable I truly can assess or not? Do I have the data I need to be able to assess this or not? And, and I think we always, I feel like we hear this all the time as kind of POCUS people, right? Is you always just kind of hear about, okay, well, maybe should we draw the line here? Should we draw the line there? Should we draw the line there? And, there's so many parallels in anything else, right? I mean, in my personal practice, I don't listen for friction rubs because I've never heard one. And so I'm probably not ever going to hear one. And so it's I just go other directions because I know I can get data I can trust in other ways, and I think it's one of those things where it's part of how you practice. And so if you're somebody who is gaining clinical experience, you're gaining POCUS experience, know what you're going to use, what you need to use, and what you don't, and put your time and your energy into those things. And so, I think it's there. Yes, there is more variability. I don't think it should necessarily mean that like no one should do it. You know, I think it's one of those things that like anything else, you have to kind of interpret cautiously and you know, and make sure that you're using good data to make those interpretations.
Yeah, and you can always get a formal echo. You can always get
You
one.
can always just order
It
the
may take
echo.
a few
Yeah.
days if you're. But sorry, Mustafa,
it's quicker now. But I was
Yeah.
gonna say, like, I mean, I love that concept that Stephanie just brought up, and the way I think about it, the way I teach this too, is that like, it's not about a boundary that you have to stay within, right? There's not a line that you shouldn't cross, right? The way I think about it is it's very Bayesian, right? Like for every single thing you're looking at, like, is this going to change your pretest probability of what you're looking clinically or not, right? And I think of the same way of like, if you're really good at LV systolic function, then yes, you should use that a little bit more, obviously, depending on what your pretest probability is. Versus like, if you're not that good at looking at the IVC, don't put so much weight in your interpretation of that POCUS, right? And it's just like anything else, is as your skills get better, you get more comfortable, you understand more of the nuances, then yes, then weight it appropriately. But it's kind of that like make your own character in a video game. Like you don't start off at a 99, right? You have to start somewhere and you know what those skills are, you know what you're able to build into. But then once you have that, that's when you can actually use that piece of information. Until then, practice it, try it, think about it, review it with someone that maybe, hey, still get that formal echo, or hey, maybe still like corroborate that.
Yeah, totally. I love the way you incorporate the clinical reasoning principles into this, because you're totally right. A patient without a lot of cardiovascular risk factors who had a normal echo a year and a half ago, who has a very weak indication for an echo right now, who has their daughter's wedding to go to that afternoon, you know, you're not going to keep them for an inpatient echo because they really don't seem to need one, and the chance of having a new abnormality seems very unlikely with clinical reasoning. So, well, that is interesting. You know, your users aren't the clinicians for the team, and that's one part it's almost like a POCUS consult service. I mean, the model that you have where expert users, hospitalists or otherwise, come in and do that evaluation. But you know, our goal as educators would be someday to have the primary team, you know, who's weighing all those things, the patient factors, how concerned is the patient, what's their follow-up? But they have an outpatient cardiologist, they can get an outpatient echo next week. Like that kind of things, like the access to care and their literacy and their own values play into it. You know, this is such an unbelievably fun conversation. I feel like the four of us could talk for hours. I'm making sure our listeners, you know, stay engaged to the key result. I think, well, of the three aims, you know, the big finding is that 66% of the exams, you know, seem to be agreed upon that could have been deferred. So don't tell third-party payers, but you know, 66% of inpatient echoes, you know, could with the exclusion criteria listed, you know, could be deferred or canceled, and that I think is a really powerful finding. So that's essentially in I guess figure 3 encapsulates some of that. So walk us through that result, and you know, in the context that you interpreted that in.
Yeah. Yeah. So it's 66% of the TTs that we captured in the pathway, right? So not all, for the third-party payers who are listening, not all of the inpatient TTs, right? Please keep paying for those. But yeah, so 66% within the, you know, within what was captured for our by our pathway there. And yeah, and so I think the really interesting thing here is that we found how challenging it is actually to get agreement and and this is where I think a lot of the clinical judgment came to head between the hospitalists and the cardiologists who were involved in the TTE triage decision. You know, we tried initially to kind of put this into like a super clean, similarly like agreement analysis, and it was all over the place. And then when we looked at the comments that, you know, that people were leaving for why they made the triage decision that they did, sometimes it had to do with the POCUS, sometimes it had to do with the clinical situation. You know, it was all over the map, and we just kind of realized this is too complex of a variable to really boil down into like, yes, do this or don't. You know, I think where we had a lot of success here is in the fact that, yes, there was agreement, but that in the majority of the agreement, it was to defer or cancel, right? And so it wasn't that there was a ton of agreement in, yes, we need this, but that it was, yes, these are ones that would be safe to not do inpatient, even if ultimately we do them outpatient. And then, yeah, and then
That's
we
on
looked at,
figure
yeah.
3 in you're saying figure 3 on page 50 of the article, the first bar reflects that the biggest.
Correct. Yeah.
Okay.
Right. So this was, I think it was like 58 out of 90, 59 of the TTs that were captured by this pathway were elected to defer or cancel. And yeah, and so I think, you know, it's complex. That was, I think, where our group had the most discussion in terms of the outcomes that we had. But ultimately, I think this is the key point of it, right? And the key driver. And this is where I think the value of this triage pathway really is.
As an add-in, I think the crazy part, right, is that we had the single POCUS images are interpreted by the individual doing the POCUS, and then 2 cardiologists looking at each one. And a lot of times the cardiologist didn't even agree on the deferral decision or not. And so we had the third cardiologist be the tiebreaker on it. And it just kind of shows just the style differences, the interpretation differences, and all these other parts of it. And good thing we had an odd number of cardiologists, so we had a tiebreaker for this. But it just kind of shows the complexity of all of these things we do to interpret the images, the clinical one-liner, and everything else that kind of comes into it. So I think it's one of those things where, like, it's kind of the beauty of this study that we were able to kind of get this done with that level of complexity. But again, I think just shows how great of a job Stephanie's done to kind of lead this from start to finish. So
let me ask, just so I'm clear, when you say deferred to outpatient or cancel, it wasn't because they were normal cardiac POCUS exams. It's just that they were, it looked like the LV function was around, you know, moderately reduced, and it had been historically moderately reduced, and so there was no reason to do a new one. Okay.
Yeah, it wasn't necessarily that it was stone cold normal. It was that it was exactly what you would have expected, either based on other clinical data or prior studies.
Like they come in with heart failure every month and have an echo that shows the same thing every time, and it gets reordered because people are like, maybe there's a change, but understood. Well, that's also a really key point about the study. If you had for instance, a lot of like normal studies, like I think I was thinking about syncope that way, that I've seen data on echo for syncope where it's very, very often very normal. But in this case, there's a lot of pathology here. So it's not that they were normal and therefore canceled. It's that the cardiac POCUS was sufficient to say there isn't some glaring new pathology that warrants an echo. Interesting.
Yeah, and then we did kind of a deeper dive on the group of people, and it was only a small number. I think it was only 4 cases where the hospitalist said, no, we don't need to do a TT, and the cardiologist did want an inpatient TT, because we figured, you know, if we were going to miss something high risk, it would be in that group. And when we looked at those 4 cases, 2 of them were canceled by the primary team anyway, right? So they ultimately didn't get done, not because of anything related to the pathway. And then 2 had no significant findings. And so we did want to then kind of like make sure that there wasn't some gap that we weren't acknowledging, that, you know, that the cardiologist would have caught.
It's a really, really important point. I saw that in AIM-3 in the results. Well, you really thought of everything here. I really do mean it. I think that the study design and the way you collected the data and analyzed it and put it into context is stellar. I mean, congratulations to you, Steph and Mustafa, and your whole team for collaborating across, you know, disciplines. I learned a lot from our chat today. I know our listeners did too. And Dr. Ritu Thamman, it's such a privilege to have you here. It's great to get your input from another institution and your perspective. And thank you for making the time today to join the is it the 11th POCUS Journal podcast? Okay. Thank you for making this session so helpful for our listeners. And again, the article is in the April issue of POCUS Journal. It starts on page 45, and it's the feasibility of a POCUS, echo triage decision pathway. So congratulations to you all, and thanks to our listeners.